Welcome to you all. It's wonderful to have you here in the beautiful Center for Orthopedics and Wellness at Barton Health. I am very honored to be able to speak with you for the next little while. My name is Matthew Wonnacott, and I'm the Chief Medical Officer for Barton Health. And we'll be talking about opioids, as you can see. Now, this is a topic that touches everybody. And some people are coming for a variety of reasons, be it personal, somebody you love, or somebody you know of, or just the topic is kind of an interesting topic. I have been here in South Lake Tahoe for just under 2 years, so I'm not a long timer yet. I've got about 20 years to go, I understand, and hopefully we make it 20 plus years. But I've learned a lot. I spent my first 26 years in practice in the Air Force and had some unique things happening in the Air Force that were different than what I've experienced here in South Lake Tahoe. But it's been exciting to be here, and this was my home the first couple of years, or first about 20 months, is the Community Health Center. And I was a medical director there, and a wonderful group of people, some of whom are here, and just really loved my time there. But this topic of opioid dependence became very important to me. And we see all types of people here at Barton Health. We've got kids, and we've got patients who are pregnant. We've got really every walk of life, except that one. We don't do that one. I just thought that was cute. I thought that was cute, so I put him in there. But no, we don't do that. But everything else we take care of in the Community Health Center. And as is present throughout the country, opioids and dependence is also a very important topic for us. We have as our mission delivering safe and high quality care, and not only that, but engaging like we are right now with the community for the improvement of health and wellness. But let's go right into right here. Anybody recognize what that might be? Yeah, those are opium poppies. The name for that is Papaver somniferous. So you hear the S-O-M-N, like, I'm somnolent, I'm tired. It's kind of similar to the word narcotic, which comes from the Latin word narcos. And that again, narcos means also sleep, or you've heard of narcolepsy. Okay, so that's how these things how these words have come, because the opium poppy has been important throughout history. You really cannot go back far enough to find out when it wasn't an important part of man's civilization. In fact, this is the Greek, or not Greek, it preceded, it's about 1400 years before Christ, is the goddess of the poppy, and from the island of Crete. And so, the gods, the god of death even, the Greek god of death, Thanatos, was oftentimes depicted with a wreath of opium. And Hypnos, who is the god of sleep, had opium when you look at some of these old pictures. But so if you take that poppy and you just score that, you get what they called lacrymus papaver. So it was the tear of the poppy, this little latex that about 14% or so of it actually can be made into the opioid medications that have been used throughout civilization. I thought it was interesting that when they take all of the components out of the poppy, this is called meconium. And it was called that before, I think they called the newborn stool as meconium. So it goes all the way back. So if you look at the family tree, the morphine is that first agent that you can get out of there, and then can be, as well as the codeine and the thebaine, which can be made into the oxycodone The morphine, of course, has a variety of components that they can produce or put into a substance that I could take in and can have an effect on me. And then later on in history, really in the last 150 years, then we have starting to get some synthetic, semi-synthetic opioids as we were using biochemistry to kind of mirror what was naturally in the opium. And so it really, opium was used all, as I've said, through all of history, and then through the Dark Ages and on up, and this is a few hundred years old, but it wasn't until really the Civil War that it became quite prevalent in the United States. And in 1874, Bayer, you've heard of Bayer aspirin, well, Bayer produced the first semi-synthetic opioid, the heroin, which was used for a child's cough suppressant and non-addictive alternative to morphine. How about that? All right, so the medication or that substance is able to bind to the receptor in the brain called a mu receptor. And as that binds, it has its effects that we've all heard about. It also then inhibits as it binds, and it stops some of the flow of this other substance. And when you stop that flow, then it puts out more dopamine, and that dopamine gives people a little bit of a high. So it has a variety of actions, and the euphoria, the pain relief, these are things that can be helpful. Well, at least the pain relief is helpful. The euphoria people, I think, just like, but then the sedation, relaxation can be helpful. So those are some of those effects that people are experiencing that we like, but unfortunately, there are so many other effects that have more problems to them. As you see here, the dry mouth, the constipation. And in fact, opioids have been used all through the past as antidiarrheals. I mean, these are ones that will stop you up. And of course, the serious problems with respiratory depression that we'll talk about when there's an overdose. But these things are all prevalent when we're taking the opioid. And I want to really talk about three that are most important in what we're talking about here. And that's the tolerance and the dependence and the addiction. And so tolerance, as described here, means that to get the same effect, I need to start increasing. I need to, over time, have a little bit more of a dose to get the same effect that I had initially. Okay, that's called tolerance, when I keep needing to up the dose a little bit to get the same response. The dependence is where you rely on, that's a pretty easy word to understand. We rely on, we need this because we have certain symptoms when we don't have it. And we're trying to avoid the bad symptoms that come when I don't have it over time when my body's used to it, which is similar, not exactly the same as addiction. Addiction is where we have such a compulsive need that I would be willing to do something that is otherwise not a good thing for me to do, but I'm willing to do that because I really need that the medication. So potentially you could even do something harmful, like go and I need it bad enough that I'm going to go and steal, or I'm going to do other things. So that's important. Now the withdrawal is being in a state that is downright, as it says here, downright uncomfortable and painful. And boy, if you've known somebody who is going through that and has been on a decent dose of the medicine or the drug, it's pretty miserable. And those are some of the symptoms that one would have, that the cramping. And people will describe to me how, and a lot of people feel like, oh, it's just the pain coming on, but it's more than just the pain. It's also the cramping and the diarrhea and these other symptoms that are very uncomfortable. So let's talk a little bit about this opioid on heroin and the withdrawal. So the start of the withdrawal really happens within the first 6 to 12 hours. And I feel comfortable, and by that about 6th hour, I'm starting to feel a little bit uncomfortable. And then that starts to peak. And for those first 1 to 3 days, it can go from being mild to being just something that people would be willing to do anything to avoid. And then gradually subside. There are some who have this withdrawal syndrome that can even persist, and they just feel uncomfortable all the time. You know, those who have studied this have found that some who become dependent, and that can happen very quickly, some will have a change in their brain such that they are always going to have a little bit of a discomfort that comes when they don't have the medicine in their system. So it's almost scary, you know. I think about as my son was, he had broken his hand and had hand surgery, had some screws put in his hand. And knowing what I know, I was a little bit nervous. I had some hydrocodone, which is an opiate. And I'm like, well, let's see if he can do without it. I didn't even want to give him one, you know. And there was pain enough that night he couldn't sleep, and so 1 tablet and he was fine through the rest of the night. And the next day about 3 o'clock in the afternoon, it was just kind of hard to bear because he had these new screws right in his bones, and I gave him one more. And fortunately after that he was okay, and ibuprofen and Tylenol was all that we needed, those 2 tablets. Unfortunately I had about 18 tablets left over that I had to get rid of. So, you know, we didn't need that many. But in that case, I was constantly wondering, is he going to be one of those that could potentially get a liking for, or could get a feeling like, oh, I need more of that. And after only 2, not a problem. But it is a concern. You know, the stats have been shared, I think, with a lot. I have heard the stat that 1 in every 4 who is prescribed a medication, an opioid, will have a problem of some dependence eventually, or have a problem getting off of that, have a need for that. That's huge, isn't it? All right. So overdose. Too much of the dose has an appearance that boy, nobody wants to see. But what happens is the patient may get, or the person, of course, is going to be very drowsy when you get too much in you. The pupils will look pinpoint. Cold and clammy skin. And of course, if you're so somnolent, you're going to be asleep, and maybe you'll find that somebody's sitting there with gurgling sounds and not breathing well, and essentially unresponsive in the worst of cases. Now, so with overdose, there's some aspects of this that I really try to hit home with people who are bewaring. You know, this is what I would see, people who come into the emergency department who are, the common theme in an overdose are these things. Either combining the opioid, that medicine, with alcohol, benzodiazepines, which is like your Valium, your Xanax, your Klonopin. You combine that with the opioid, and a much higher risk that you're going to go through those into overdose, okay? So that's a big concern. Certainly what is becoming more and more prevalent is that the heroin that a person might be getting, or whatever medicine they might be getting, may not be pure what they're used to getting, okay? More frequently now, we're seeing fentanyl, and we'll talk about that in a second, or some other powerful opioid that's been mixed in there. And so these impure things that you're not expecting, and it might be put in there just so it's a little bit more addicting, but it can be extremely dangerous, obviously. So then this just states the amount of the opioid that we start getting really concerned about is greater than 90 milligram equivalents of morphine. So each of those medicines that I was describing before has a certain amount that it's equivalent to this much morphine, and we kind of use morphine as the standard to tell us this is objectively about how much of an effect of the opioid they have in them. So at this point, we start having more concern, and there's certain laws that are now coming out that use this level as the amount of what I have to do something differently as a physician. And then, and this is probably, I put this last, but I have seen this probably more frequently than anything, and that is somebody who has been off of the drug for a while, may have gone through withdrawal, might have even been a week or two or months, and then something happens to where if it's something emotional or some reason that they say, I'm just going back to my med, to my drug, and they go back to the same dose that they stopped. And remember tolerance, the word I shared with you? So that person had become tolerant and had increased the dose to get that same effect. Well, all of a sudden, they take that same dose on a body that's no longer tolerant to the drug, and they die. And so these are the things that I think of that are most scary to me, is combining it with other drugs, and the things I mean, the unknown substance, that's a hard one to get away from when you're getting it off the street. But I can, be careful with anything else I'm taking with that, and then be very cautious when you start a medication that you've been off of for a while. Okay? I thought this was just so dramatic. This is from Ohio, but this is a couple who did not die, but they were saved, rescued, but there in the back seat is a 4-year-old, just sitting there in a car seat with mom and dad almost dead in front of him. And what a sad state. I thought that was dramatic, and I'd throw that in there. But it's a difficult thing. The overdose deaths, and you've all been hearing this a lot in the last 2 years, has just been skyrocketing in the last little while. So we went from 2002 down here to 2017, when almost 50,000 deaths in the United States occurred due to opioid overdose. So that's huge. When you heard the government was coming out with the bill we'll talk about in a minute, and they said that every 3 weeks we're having a 9/11. We're having that many deaths in 3 weeks just from this. More than we have from car crashes. So it's pretty remarkable what's been happening. And I'm going to look at that a little bit more. This is a graph you'll see quite frequently when we're talking about the change in the last 18 or 20 years on opioids with the different types of medicines that are being used that are causing the deaths, just jumping up here. The light blue, you can hardly read that, but that's the heroin. And then these are the prescription medicines right here. And then this darker green line right here are synthetic opioids other than methadone, things like the fentanyl, okay, or more potent synthetic opioids. But I'm going to break that down into just show you that timeline real quick. And you can't really read this, but I'll tell you. There are 3 waves in this that I'm going to talk about. Starting about the turn of the century, when there became a real rise in prescription opioids. And it's amazing when you look at the numbers. And this was, I had been a resident before this. I was brand new in a practice. And I do remember some of the talk about, well, we need to treat pain a little bit more than we have to be more sympathetic and careful in helping people and treating that pain. So, in fact, some people would blame Big Pharma because that was a time when those who were producing the medication were just really saying, hey, this is not addictive like you thought, like you would think it is, which ended up being completely false. And they're paying out a lot of money for that falsehood. And then there were even quality experts who jumped on, and I didn't dare put Joint Commission up here. I didn't want to get them mad at me if they ever saw these slides. But I can point out that the Joint Commission put this out in 2001, Current Understanding of Assessment, Management, and Treatments, and in treating chronic pain. Pain management through measurement and action. But in there are some of these statements that came to me as a medical professional that said that the patient is the authority on pain. You have to believe them, which, yeah, that makes sense. I don't know how much pain you're feeling, so I just have to go with what the patient is saying. And then it actually stated in there that it's a common misconception that opioids, that the patients taking opioids will become addicted. And we were being taught at that time, a very small number are going to become addicted. In general, patients in pain do not become addicted, although the actual risk of this is unknown. It says it's thought to be quite low. And then they started talking, they meaning, the experts were saying, to be more helpful to our patient, pain is really the fifth vital sign. I can do the blood pressure and the heart rate, but I have to also include pain. Out of 1 out of 10, how much pain are you feeling? And it's important. People are in a lot of pain. I've had people tell me 1 out of 10, no, the scale's wrong. I'm 12, and I'm okay, you're 12, that's a lot of pain. But there were times when the surveyors would come and they would look at how well I was treating pain, and they would say, you aren't taking care of the pain well enough. A lot of pressure for people to say, okay, I can treat the pain. And consequently, I might have gone past that, but let me see, I did go past it. There I did. Look at this, the prescriptions from 99 to 2011, look how much that went up, prescriptions for opioid medication. Isn't that remarkable? That much of an increase? And so that's I think when we're looking at opioid death and we're seeing this rise in the number of deaths due to just the prescription drugs, that was the wave one, okay? Because there was just so much more of it out there and people being able to use that. Well, then about here, what started to happen? Then it was very apparent to me as a physician that, you know what, a lot of my folks are becoming dependent. This is not good for chronic pain. I need to figure out something else because I'm seeing a lot of the harmful effects going on. And so a lot of people started pulling back. And when you're pulling back and somebody is independent and they don't want those withdrawal symptoms and they'll do almost anything not to have those withdrawal symptoms, what's going to happen? If they can't get it from the doctor, they're going to find it some other way, right? And so I think that's a real reason that you see this yellow line, which is heroin overdoses, starts to rise. And then finally, this rise in these new synthetic or very potent opioids. The fentanyl that you're hearing so much about it came about, we're trying to treat this bad cancer pain, and it's very important that we're able to help people with this, which is wonderful. And you're so grateful for it, but unfortunately that gets abused. It gets into hands, and it becomes such a problem. And so this is just showing about how much of an increase this fentanyl is causing in the overdose numbers. So this is stating, if you can't see it up there, it just shows from 12 to 15 in 3 years, 196% increase. And actually it's really in 2 years, almost a 200% increase in overdoses due to fentanyl. So it's quite remarkable, and it just kind of gets mixed in with the heroin or even in with cocaine, which is not an opioid, but they'll mix it in there because what's the goal? It's to get people hooked and be able to get money off that. So Just much more potent than morphine is the fentanyl. So let's talk about where we live, okay? So in California, the overdose deaths have kind of, gone along with the nation, and have gone up, and we're at a point where it's not gone up quite so dramatically over the last couple of years, but it's still much higher than it was before the 2000s, when we're talking about. And if you look at those deaths by county, all this dark red is where per capita you've got the most overdose deaths. And unfortunately, El Dorado is red. Good and red there. Okay? Northern California, per capita, isn't doing great. I'm sure they have a lot down here, but per capita, we've got a worse problem. Okay? And then, of course, no big surprise here. Or is it a surprise that California is like almost tripling everyone else in how much they're spending on substance abuse? Okay? So the next state spending the most on substance abuse is Texas, and look at that, it's like half. So California is doing a good job of spending, and we're hoping that is going to make a difference. So let's go to Nevada, since how many of you live in Nevada? Some of you do, I'm sure. Okay. Well, nothing really happens too much when you step over the line. It's kind of similar. But the total deaths has not really risen. It's already higher. The yellow is just the total amount of deaths. It really rose, and it's just kind of staying stable at a higher rate than it ever had been before the turn of the century. And the heroin overdoses are going up a little bit, overdose deaths. And this is just showing our area of Nevada, and we're talking Douglas County here, for high school students who have used an opioid that was not prescribed to them. And look at the number, 1 in 5. That blew me away when I thought of that. 1 in 5 took an opioid in the last year that was not prescribed to them. So we're winning in this part, or losing, I guess. And this is high school and heroin. And surprisingly, in Douglas County, right here, this dark blue, 9% of high school students have tried heroin. That blew me away. Yeah. Well, so the others are, this is Churchill, Humboldt, Lander, Pershing, and I don't know all the Nevada counties, 2.1%. The next closest actually is 4.6%. So Douglas County is doubling the next county per capita that has high school students trying heroin. That's scary, huh? All right, so let's go to really just our community. And if you didn't know, Barton does a community health needs assessment every 3 years. And we love the information that we get, and it's kind of turning out the same in the last couple times we've done it. It has not really changed much. Guess what was one of our prime problems? Opioid use and substance abuse. So this is just basically a graph that shows who was surveyed, equal men and women. It kind of, you don't need to really look at this too closely. But in that survey, I'm just going to pull out a couple of things. First of all, surveying our own community, what have we experienced? Unintentional drug-related deaths. And this little rain cloud, it's a rain cloud if you can't tell from a distance, just means that we're worse than Nevada as a whole, California as a whole, the United States as a whole, and then the goal that we had in with the public health people. In any case, we're much, much higher than other communities on average. PSA is prime service area, so that's the area that we're surveying, our people, okay? I just threw these in, this isn't opioids, but in case you didn't know, there's also apparently an alcohol problem. And I thought pretty remarkable how much higher we are than other places. But then the next little graphic was percent of people whose life is negatively affected by substance abuse. 57%. And this is, we didn't have a comparison for every group. In this case, we did have a comparison for the United States. And in general, in the United States, they said 37.3 people surveyed say that they are negatively impacted by substance abuse. And yet we're 57, so much higher. It's a party town, is that it? Okay. And this just is showing that in that group for substance abuse really negatively affecting you, it's not just the rich or the poor, the old or the young. It's everybody. It's kind of across the board, okay? And again, another comment on those who used opiates in the past year. And that means they could have been prescribed or not. But a pretty large number, when the number's 22.1, that's nearly 1 in every 4 people who live here have used an opioid in the last year. That's a lot to me. I think that's pretty impressive. And so key informants, these key people who were taking this survey, were asked specific special questions which stated, in their opinion, and this may have been some physicians, and I don't know, Natasha, what the different key informants were all from, but what they determined was that, what they said is that substance abuse, this red here is saying that it is a major problem of all of these problems that we were assessing in the needs assessment for the community. And you know, this is heart disease, stroke, and injury and violence, and various other problems, arthritis even, oral health, dental care, tobacco use. Of all of those health problems, number 1 that people feel like is important in our community that we need to work on is substance abuse, okay? And this is just showing, the primary thing that our key informants were really worried about, they have alcohol here. So we have a real alcohol problem. But then the next, with heroin and other opioids. And then if you add into that just prescription medications, which includes some opioids, then it's going to be higher than this. But what this is just, again, emphasizing is substance abuse is such a problem. Okay, I'm going to go back in history again. And these are the British and the Chinese. Anybody know the name of the war? The Opium Wars, right. So again, opium, been around since the very beginning, and people have always had these problems of addiction, and that addiction can lead to wars even. It's pretty remarkable how you see this cycle. And here China had been one of the main users of the drug, and the British were helping them get it from India. And when the Chinese government said, this is back in the 1830s through 1860s, when the Chinese government says, we've got a real problem, our people are not doing well on all this opium, they started to put all this tariffs, started to make it difficult for the British, and that alone caused this war. Well, the wars are like continuing. It's remarkable. This is in Afghanistan, and I was there in 2011, and you know, this is an article saying, hey, we're really excited that poppy season, they're about to harvest their opium so we don't get so many battles going on here, you know. What an effect the opium has on everything, even war, is remarkable. But there's a war going on right now, right, from our government. And there's our president saying that opioid crisis is a national emergency. We need to do something. And so what'd they do? Just the end of last year, we had the House bill number 6, and it's the Support for Patients and Community Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment for Patients and Communities Act. They do a great job with acronyms, don't they? They like come up with some really great ones. It takes you about 20 minutes to try to figure out what they're saying. But anyway, it unanimous, I mean, huge, easy win It was almost unanimous vote for that. And it was really, they kind of pulled together a whole bunch of different ideas, and a whole bunch of money needs to be spent to figure out how we can fix the problem we're in right now that you saw from 1999 till 2017. We got to do something. And so we're going to spend a lot of money. We're going to try these opioid treatment programs. And we're going to talk about MAT here in just a minute. That's medication-assisted treatment for opioids. And then the states are also obviously getting involved. And so last year we started having new requirements that the state of Nevada was putting out there. And we at Barton, we're interested in Nevada because that's part of our prime service area, and also our medical record comes, so we share that with Renown, and they're in Nevada. So a lot of the things that we do with how we're documenting and things needs to comply. And so in this AB 474, then there was a movement to, we had to be much more careful in our prescriptions that we're writing. The licensed prescribers needed to get a certain amount of education on opioids, and then we have to check the database when we're prescribing. Each of the states have a particular database so that we can follow and we can check on somebody who may be getting opioids or whatever medicine that could be controlled, and we don't want them getting a bunch, and yet they're going to different providers to get that. And believe it or not, California will not be outdone when it comes to regulation. And so, here we had AB 474 from Nevada. Well, we've got 14 bills. In fact, they were discussing over 26 or so bills just for opioid use and substance abuse. So there were 5 of them that were just talking about how we can curb the amount of prescriptions that are being dispensed, from requiring electronic prescriptions because that's easier to track, to the prescription pads have to be specific and different with serial numbers, and that just started January 1st, and that's been a challenge for all of our doctors' offices to all of a sudden get the new paper that it's supposed to be on with the serial numbers, and a variety of other things. But provider training on addiction is one of the state bills, and then to educate on treatment and management of opioid disorder or dependency. So there were those 5. There was one bill on expanding treatments, which means that there's what's called a drug Medi-Cal program that helps those who need counseling, and there's not enough money for counseling for this particular problem of substance abuse. So we're going to put more money towards that so people can get the help they need. And then the Narcan or naloxone access to a medicine that is a antagonist or a blocker of the opioid that could be used in somebody who is overdosed. You saw those 2 people in the car. They would have gotten Narcan right then. It would have reversed the effects. And so the database, so Nevada has their own one. You saw is PMP, and there's a California one called CURES. And I don't remember what CURES stands for. It's another acronym, but it just is the database that I have to check every time I'm prescribing that medication to ensure that there's no other prescriptions from coming anywhere else. And regulating rehab, as well as storing and dumping drugs safely. And the state is looking to those drug companies who are producing and selling the drugs to also play a part in the taking back of the drugs and helping pay for that. So a lot going on there. Now, I'm going back in history one more time to just talk. This sets us up for that medication-assisted treatment. Back in the Civil War, remember I told you that's when it really became a problem. We had all these soldiers who needed something, and so that opium, that derivative was given to them, and it helped those amputees and others. And it was really something that the country was very supportive of those who ended up needing the opium, needed the morphine, and I should say the morphine. And in fact, we also had it was the upper class that started getting dependent on the morphine. And so all through that century, the country was actually very supportive and, oh, we'll take care of these folks until about the turn of the century, the 1900s. And we got into the 1900s, and then the view really switched. And instead of, oh, we're going to feel sorry for folks, it started to become more prevalent on the streets. And this is just a picture of people who were arrested for vagrancy, but that was also a lot having to do with they were addicted on the drugs that they were using here. And so in 1914, there was an act that said patients can only be treated, or doctors can treat substance abuse, but because to be a patient, you have to actually have a medical disorder, and it was determined by Congress at the time that this wasn't a medical problem, this was a behavior problem. Therefore, they're technically not a patient, and therefore you cannot treat substance abuse. So, it's a difficult thing to kind of understand, but in essence, what this law was stating is physicians may not treat opioid use disorder with medication, because we're not going to believe that opioid use disorder is really a medical problem as much as it is a behavior issue. And so when I talk about being able to prescribe now and we have a waiver for that prescribing, this is why. It goes way back then. And so the idea was either this is like some person who is just weak-willed and there's all these other environmental predilections, but the way we fix this is simply by tapering them and then ensuring that they are abstinent, pulling it away, keeping it from them. That's really the only answer, is I'm not going to prescribe it, and that's the final answer there, versus that this is actually an incurable disease that requires long-term maintenance with medications. So where in that spectrum are we? I mean, I think everybody has a little bit of a different idea of where we are. But I have learned a lot in the past couple of years, and I've learned a lot how people they're that 25% that have a change that are very uncomfortable, even years later, that it may very well be something that is that disease that's talking about here. So the medicines that then have been developed that can be used for this. One is methadone. You've all heard of methadone? So it's an opiate. It's a long-lasting opiate that you take just once daily. And here's some advantages of this. The methadone is truly a full agonist. It's a full opioid like morphine, but it's long-acting, and it really kind of blocks the effects of other opioids. If I'm taking methadone every day and then I add heroin to it, it's very dangerous to do that. It doesn't give me much of an increase in euphoria, so most people don't do it. But it is dangerous. Tolerance. Methadone does not have minimal tolerance. You don't have to keep upping the dose. Okay? Euphoria. It doesn't have a big euphoria effect. It's not very sedating. Compared to others. It doesn't have that same craving. And all of this really is useful because then you're actually having an easier or less of a withdrawal type of a problem with methadone. Now, as I said, methadone is a full opioid. It's like heroin in the sense that it fully turns on remember those receptors I showed you in the brain? It fully turns those on. And so it is dangerous. But it's these certain effects that I said make it much safer than if I'm constantly using heroin, okay? Or it makes it so that I can treat that problem and maybe be more functional. And then the second medicine to mention is buprenorphine, and buprenorphine is also an opioid. It's what we call a partial agonist. It doesn't turn on that receptor completely. And there's some real advantages to that. So it has these same properties it makes it so that you don't feel much of anything if you take heroin while you're on it. It doesn't have an effect of tolerance or it doesn't have that big of euphoria that you get when the dopamine hits, and You don't get sedated as much. And so it's wonderful, but the nice thing is it's partial agonist, and I'll talk about that here in a second. The other medicine I wanted to mention is the naloxone. Do you remember what this was for? It's a blocker. It's an anti-opioid, okay? So we'll show you some examples of this, and one of the brand names here is Narcan, and that's something that at the end of this talk, we'll have just a couple minutes. People can stay and they can learn more about this, because this is a medicine that now is becoming mainstream for people to have just in your medicine cabinet if the one you love is on the medicines. It's something that you could save a life with. And so becoming more and more prevalent, and you saw that some of those state laws in California were about making it easier to get this out there for our law enforcement to have on hand, to everybody who's on these chronic medicines to have on hand. Naltrexone is also an opioid blocker. It's not one that we use to immediately reverse the effects of these opioids, of like, say, the methadone or the morphine or the heroin. It can be used to decrease cravings over time. It's a much longer acting, and it doesn't have the same effect. It doesn't just all of a sudden reverse within minutes the opioid problem. So I just thought I'd mention that because it is one that the doctors may use. So these are available from any provider. And you'd have to talk to the doc if naltrexone may not be what would be best in your situation. Naloxone, again, could be prescribed if you needed it because your loved one, or you're taking the medicine and you want your loved one to have it on hand in case something were to happen and you had an overdose. The methadone is only in the treatment centers. You cannot get this at an outpatient clinic. You can't get this in South Lake Tahoe. Because you have to go to a treatment center, and the closest treatment center on the California side is Roseville. It's quite a ways away. And I believe there's one in Douglas County. I just don't remember where that is. But if you were using an insurance from California, you'd end up be driving to Roseville, but they were getting a spoke, built a new facility. A piece of that facility is going to be moved to Placerville, so it's a little bit closer, but that's still quite a distance, right? The wonderful thing is buprenorphine, which is in Suboxone. That medicine is available from an outpatient clinic as long as the provider has that waiver that I mentioned. Okay, and we'll just go a little bit more about that. Okay, so quickly about the Narcan nasal spray. Those who are interested, when we're done, you can actually get training, and then you could walk away today with your own Narcan, okay? And there are people who just carry that in their purse all the time because they may be among a population that is at risk. They might see them, remember those overdose symptoms? They see them there, and they're a little bit blue, and they're not breathing right. The Narcan may be the lifesaver in that case. Certainly, when you do give it, it not only wakes them up, what else do you think it does? Yeah, it puts them in extreme withdrawal. So they're probably going to be pretty dang mad, but they'll be alive. Okay? So that nasal spray, it's a simple, spray it in a nostril, and then you can repeat that if you need to. Immediately you're calling 911, of course, because the effect could wear off and they could go down again. We need to get them care. But that minute, within seconds even, getting them that Narcan certainly could save a life when it could be otherwise many minutes before they'd get any care. Okay, so let's talk about that. So this is the naloxone I just mentioned. It's an antagonist. It blocks the receptor, doesn't have any effect. You don't get anything out of this. In fact, it pushes out the heroin or morphine that's attached here, and it blocks it all. And that's why they go in withdrawal. That's why they wake up. Okay. Buprenorphine is the medicine in Suboxone. I mentioned that that's a partial agonist, meaning it doesn't totally turn on that receptor, but it has very strong affinity to that receptor. Meaning, when you say affinity, that means it will kick anything else out. If you got heroin on there, if you got anything on there, it kicks it out and it sticks, and it is the strongest. It's the most sticky to that receptor of all these. And this is just showing a full opioid agonist, which includes methadone. The reason that we use that methadone is because it has those other properties that are good, but we still have lots of methadone overdoses. Okay, so it's not like it's as safe. Whereas with the buprenorphine, you actually don't, you very rarely would have an overdose death. And the only deaths I've heard of is when you're combining it with alcohol or benzodiazepines. So you can get a pretty high dose. In fact, you can fill up all those receptors, but remember, it's not turning them on all the way. And if it's not turning them on all the way, then it's not going to stop your breathing, which makes it much safer. So it attaches, it can give you that fix that's needed without the danger. So this just shows the full agonist, that as you increase the amount of it, it causes you to stop breathing. And this shows that you give more and more buprenorphine and it stays down here, and you're not going to get to that point. This also represents how strong it sticks, the affinity that it has. It'll kick off heroin. So if I all of a sudden took somebody who has had heroin in the last 6 hours and I give them buprenorphine, guess what happens? They also feel a significant withdrawal, okay? Because all of a sudden it kicks out the heroin, but it's only partially activating that receptor. And so people will actually go into withdrawal by giving them this opiate, which is remarkable. But it also sticks so strong that then if I add anything else to it, it's not going to kick that off. It's going to stay there, and it won't have any effect. I had a patient who said she felt just really lonely, and she just felt like she just needed it, and so she went and injected heroin, but because she was on buprenorphine, she didn't have any effect at all. She didn't even notice it. So it's sublingual. It doesn't go in the stomach. It doesn't get absorbed there. We have to absorb it through our mucosa, the lining in our mouth here. And interesting, buprenorphine is in Suboxone. What else is in Suboxone? It's naloxone. That's the blocker. But remember, buprenorphine is most affinity of anything. The naloxone being in there combined makes it so that people are creative, and they would take these films and they'd melt them down and inject them because that gives you a really quick response. But if you have naloxone in there, it doesn't do a thing. And so it's really only thrown in there because of the potential that people would have to abuse this drug. Okay? So it's a combination, buprenorphine and naloxone. And you get from 2 milligrams of buprenorphine all the way up to, you can get up to a dose of 24. Some people may go even a little bit higher using this once a day. Okay. Some people will take it twice a day. They'll even cut it up and take it twice a day because they feel like that just makes it a little bit more even throughout the 24 hours. But really, once a day for most people is that's how we will prescribe that. Okay. So if I'm going to take somebody who is on who comes in to, say, the emergency department or to the clinic, and they are obviously having a problem with dependence, then we have an option to use this Suboxone. And there are certain steps that we will take, and they'll sign an agreement. We'll explain how it all works. We actually want them to be in some withdrawal. So if I'm going to start Suboxone, I actually have them stop. I have them wait a while since their last dose of heroin because of the withdrawal. It's more comfortable if I actually get them into a state of withdrawal first and then start the medicine, and then it's like, oh, that's relieving. Whereas if I gave it while they were still high, then they go through a worse withdrawal, remarkably. So I'm going to put them in a little bit of withdrawal, look at those symptoms, and we have a little measuring thing on how bad the symptoms are that we can count up. We'll also do a drug use survey, which gives us an indication of how much of a problem they have that might be helpful to add counseling in with this, okay? We know that medication's only part of this, and so if we're going to get the appropriate counseling, we're going to see what their use is like. What are they doing with that? And as we give that medicine, we can titrate it up and get to the dose where people feel I've had people, they just know 8 milligrams, that hits it. That's perfect. 12 milligrams some people, 20, or up to 24. And we'll see them repeatedly, quite frequently initially, and then when somebody's been on this medicine for a long time, maybe even out to a month. And then there's the question of is this truly something that we're going to go on forever or not? And so the experts in addiction say that there are many people who will use this the same as a high blood pressure. A person with high blood pressure would use an antihypertensive. And that it will be used for that person for the rest of their life, just like they would be taking a blood pressure pill. Remarkable. So that's a question to speak with a doctor about. What's the long term? And so I usually tell people, don't plan on this being we're going to take care of this over the next month and then you're going to be off. I work with people to see what they're going to be most comfortable with. Let me just mention that this isn't pain management. Buprenorphine it does help with pain, but it's not a primary pain medicine. So we're talking about opioid use disorder, and that's why we actually, before we start Suboxone, we make sure that that's a good candidate for it, somebody who's truly dependent. And if I were using buprenorphine just for pain, I wouldn't even need that waiver. But really, we use the Suboxone just for opioid use disorder, because it's not the best medicine when it comes to treating acute pain. And chronic pain is a different issue. Chronic pain, we've got to find the underlying problem. If there is a physiologic problem that can be fixed, we need to work on that, right? That's the primary thing we do. So let me just finish. I'm about done. Dr. Velasquez at the Community Health Center in Cameron Park, down in Placerville area, she is working hard towards what we call needle exchange, which seems so counterintuitive to, you just like, I would give needles to somebody who I want them to be off of heroin. But it's interesting how bad, look at this. This was out in a park area. Somebody had stolen a Sharps container and for the syringes, okay? And look at this. People will go out in these areas and get just huge bags full of needles. It's terrible. And so we have other medical problems when we're sharing needles, right? Like hepatitis C, and this is from 2010 to 2015. Hepatitis C is going up because, remember, heroin use went up, and it all follows itself. And so fortunately, we can treat hep C, but we want to stop all of these new diagnoses. So this is a van that goes around and will actually take away needles and provide clean needles. It's kind of a strange idea. Okay, so let me finish now. Minimize exposure to opioids. We want to be careful. As a physician, I need to prescribe fewer to begin. We'll really assess the problem, but I think the days of giving out 30 or 40 after a surgery even are gone. It's going to be a small amount because you might be in that 25% that's going to have a problem with that, okay? Openly address dependence. It's a real issue. It's a medical problem. The Narcan, lessen risk for overdose death and other disease, and then provide access to treatment with this. So we have a few of our providers who are, I don't know, Sierra, have you got your waiver yet? Not yet. Hasn't come in the mail, but we got a few providers who are to work under me as the medical director for this issue, as their supervisor, who would be able to prescribe. This is something that not everybody is going to be the right candidate for it. I don't want to say that this is just like the fix-all or at all, but we have the capability now in South Lake Tahoe. Prior to me, there was one physician who was doing it, and he had stopped doing it a few years ago. He's just for various reasons. And now we're working on getting more and more trained. And we've got a couple there in the Community Health Center who have been, they've decided that I'm going to take that training. We get 24 hours of, this kind of stuff, so we know about it, and then we can prescribe it. So for those who have a problem, this is really a wonderful, let me just share with you finally, and then I'll be done. And I have patients, you know, I mentioned every demographic is affected. I had a patient who is completely functional, has a great job. You would never know. She has a few issues that I could tell there was a problem, but she finally asked about this. And I started asking her questions about her history. And she had had a surgery many years ago. She'd been in a motor vehicle accident, a car crash. And she got the drug, and then she repeatedly got some prescriptions. And she had continued to have that craving for a few years. And here was a very functional person you would never guess, looks as good as all of you, and y'all look great. And yet she said, and I'm trying to, it can't be that bad. And yet she finally says, well, I've just been getting methadone from a friend. Who would have thought? And so wonderful, wonderful. Once we got her on the right dose of buprenorphine, she was like, oh, I'm much more comfortable. So you have that end of the spectrum. And then I've got patients who have come in who are just on opioids, have taken the heroin, has taken them out completely. They're homeless, without family or any, it's amazing. I had a father whose daughter was in jail, and she'd been in jail for 3 days. So she'd been off heroin for 3 days. So she was like crawling out of her skin. And he called me and said, I remember you're talking about there's a treatment for this, and can I bring her by? And I says, bring her by right now. And so she got out of jail. He had not seen her for 10 years because she had been out doing her thing and homeless. And brought her to me, and she was writhing on the table. I mean, it was hard. I couldn't have any conversation with her. It was really a mess, and she just looked terrible. I mean, hard to describe how terrible it was. You just felt for her. It was uncomfortable being in the room. And we started her on the medicine, and I could start it right then, right? She's already in withdrawal, and so she's going to have a good effect from it. And we were able to get her the medication. And about 4 days later, my assistant came to my office and said, so-and-so's here, and she wants to ask you a question. And I go, oh, is she doing okay? And she goes, yeah, you go see. And I go to the lobby, and I looked out at everybody, and I didn't see her. And I go back to my MA, and I said, she must have left. And she goes, no, that's her in the corner. And I went and I looked, and she had a great appearance. She was like put together, her hair, I mean, it was just amazing. And I went over to her, and she goes, you didn't recognize me, did you? And I says, no, I didn't. And I took her back, and she had some questions. Can we do this with the dose or whatever? And then she talked about how she's working now with her parents to get a job, and she's going to be doing this and that. And it was and I came away from that feeling like I had done more good than almost any other visit I had done the whole time I'd been at the community health center, because I'd taken somebody who was so dysfunctional and gave them a tool that at least made it so that they could actually function. It was really wonderful. So you have all types, and it's been an hour, so I should be done. But I'll probably answer your questions. That's one of my favorite pictures, and that's Barton Health. Okay, so I'll take questions.